Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, we are the Millennial Mechanical Therapist, and today we're going to talk about how we treat the other category in the categories designated by the Mechanical Diagnosis and Therapy.
So as we're going through our mechanical exam on every patient, we can get into those three standard subclasses or classification: your derangement, your dysfunction, or your postural syndrome. There's also a fourth, being the other category. If you've read the textbooks or if you've gone to any courses, these get talked about pretty well, but for the most part, especially in courses, you're focusing on those three. You're really trying to get through those three classifications. The books do a great job of going through the other category.
They do.
Whether it's the lumbar text or the cervical thoracic texts. The extremities text was a little bit.
I don't think there was
too
much.
I don't think it was as much. It's the extremities text style, at least the latest edition, is just a little different than the spinal versions, but neither here nor there. When we go through our mechanical exam, we're looking to classify into one of those subgroups, and if over 2 or 3 visits that they don't fit one of those 3 primary ones, or if something in the history and the objective exam really stand out and make us think that it's one of those other categories, we have to change our style of treatment depending on that classification. So with the 3 classifications standardized by MDT, there's a pretty easily correlated treatment that you're going to prescribe to that patient, and it's pretty standardized. You've got your repeated movements either to reduce the derangement, to remodel the dysfunction, or posture correction to reduce the stress from a postural syndrome. You get into the other category and all hell breaks loose, and it can just be about anything pretty much. So that leaves you, if you're going through MDT, what do you do?
Yeah.
So
and that can be tough, especially when you're, if you're practicing with this mindset and really trying to do your best job classifying everybody. You're going to find that the majority of individuals that you see respond relatively easily to repeated movements. The majority of people that walk in your door are derangement, and there's articles out there that support that sufficiently, that about 70% of those that come in, give or take, are derangement. So that you get kind of bored in the minutia of dealing with derangement. Every now and then you may see something right post-operative and things like that. You'll hit a dysfunction. If you're seeing a postural syndrome, that's rare. But these other categories, we're talking about things like stenosis. Post-operative does fall in the other category. Things like for maybe like the spine, Sowerman's disease, and other things that people can deal with that don't necessarily respond to repeated movements or static loading, that don't necessarily act like a dysfunction or postural syndrome, but yet this person has significant complaints, and how do you approach that in similar fashion that you approach everything else? And
the other category, especially recently, runs into a lot of problems because a lot of others, as we think of them, are pathoanatomic diagnoses. The ones that Joe mentioned, it's a post-operative, so usually that means that they were diagnosed with a meniscus tear, a labral tear, torn rotator cuff, things like that. Things that have recently really fallen under, very skeptical eyes with incidental findings in asymptomatic populations, the idea of pain science and the nervous system, is that where things are stemming from, ascending, descending, nociception, things like that. So when you get into the other category, the way that we typically approach it is still classify. So as you go through the other category, you have all of these different potential diagnoses. Now, if you have a post-operative or if you have a trauma, someone who fell, those are essentially the same thing. I mean, surgery is just planned trauma.
Yep.
Frankly, that's what it is. So in the beginning, you really want to go through your stages of healing a bit, and if you follow the MDT paradigm, you want to follow the traffic light and make sure that as you're going through, you're not over-stressing any tissues. You want to really let things heal and promote that healing and that range of motion in the beginning of trauma and things like that, because we know that people are going to get better if they get hurt. They just have to get things as loose as possible in terms of the range of motion and just make sure that everything is working appropriately while the tissues are kind of taking care of themselves. At the same time, you want to make sure you grade your exposure to any inputs. That is going to take care of that neurological component in terms of the way that the nervous system responds to anything occurring. So you don't want to just throw somebody to the wolves and put them on the bike on level 17 when they got out of surgery yesterday. I mean, that has a whole lot of problems to it, but one of them is you have to grade that exposure. Put them on without resistance first and make sure that they don't fully revolve, just go a little bit and then come back. And a lot of times for the other category, you fall back to the things that you learned in PT school. I mean, when you go back to that, it just basically search and destroy impairments.
Yeah, I agree 100%. I think that I know we both like to use is if you're familiar with the system and you've found a dysfunction, you talk about like the yellow light where you have to produce discomfort, but that discomfort can't be any worse after about 15 minutes. I use a lot of that analogy with my patients who are in the other category who are trying to get them to move, that they have to move to in a comfortable point till they feel a mild discomfort, but that discomfort shouldn't last long at all. And that's how they start remodeling those tissues, so to speak, and start moving through and kind of destroying their impairments. So I think if you can keep a simple mind, you can give them very strategic, very specific exercises that may be they may be termed general, but they're specific to that individual, and still get really good results from this other category.
I think that's a great way to put it. It's thought of as general, but it's specific in the fact that we know that's what they need.
Yeah.
So that's the first part on our take on kind of how we approach the other category. We're going to have a follow-up video coming up, and we're really going to highlight why that traffic light symbol, or that analogy of the traffic light, is just so important, at least in our practice.
Definitely. Like we always say, friends, move your patients early,
move them often,
and move them till end range, because that's where the magic happens. See you next time.
See you guys.